Welcome to IRG's Health Talk. I'm Tom Hutler along with Shannon O'Kelly, physical therapist and president of IRG Physical and Hand Therapy, and our guest, Dr. William Wilson, orthopedic surgeon from OPA Ortho.
Dr. Wilson, welcome. How are you doing today?
I'm fine, thanks. Thanks for having me.
Absolutely. Hey, I'm really interested in talking with you, but before we get into the questions, I want to get a little bit of feel of your background. You've been an orthopedic surgeon you've got a lot of experience. Tell us about your experience and your interest in that area.
Well, it goes back quite a ways. I was a West Point graduate. I did some line duty as an infantry officer, and then I decided I wanted to go to medical school. Finished up and got my degree about 35 years ago, and spent 15 years total active duty Army service, 10 of which was as a orthopedic surgeon taking care of soldiers and retirees. And then I left the military and moved here to Seattle, and I've been in practice here continuously now for 25 years. And
you have an area of interest in your practice. You do a lot of what we call extremity work. I mean, tell us your practice, what specifically you specialize in.
Well, over the years, it's pretty much narrowed down to pretty much just knee and hip surgery, and most of that is joint replacement surgery, replacing artificial joints for arthritis typically, and then oftentimes having to try to salvage or redo implants that have not worked out or have failed for whatever reason.
Okay, so you've been doing total joints and have quite a bit of experience in this area. There are times where you have a implant that maybe doesn't work or needs to be revised, or there's an injury. An example just recently, I think John Kerry. We know John Kerry, we know that name. He basically had a bike accident. I think he might have irritated the femur, fractured the femur below the implant. So maybe set that up. Tell us what's going on there and what the concerns are when you're looking at a total hip that needs to be revised, or there's a fracture in the femur in that area of the total joint replacement.
In general, hip replacements can fail in the long run through two mechanisms. Number one, the articular surface, so the bearing surface can wear out. Like any mechanical device, there's a bearing surface, and that's subject to wear. And if the bearing surface wears out, the implant may need to be redone. And the other thing is that these implants need to be rock solid in the bone. If they're loose at all in the bone, they wiggle around even just microscopically, they're painful. But if they're rock solid in the bone, it's like they become part of the bone and you don't even feel them. So if the implant loosens or it wears out, it needs to be redone. Another less common way that an implant can fail is what we call a periprosthetic fracture. It means a fracture of the femur or the pelvis around that hip replacement implant. And those can be particularly challenging for two reasons. Number one, your primary goal is to make sure you get the bone healed, especially if it's a femur fracture. You can't walk on a fractured femur, fractured thigh bone. But also that fracture may affect the stability of the implant as well. So you may have a well-functioning total hip. You have an accident of some sort, you fracture the femur around that hip replacement, and it can affect the stability of that implant and cause it to loosen as well. So then you have to not only revise the failed implant, the loose implant, but also do something to stabilize the femur. And that usually involves some sort of plating or bone grafting, and it can oftentimes be very challenging.
Yeah, that sounds very challenging, particularly for an orthopedic surgeon like yourself, that you have to assess how to fix it. And then also, I think it's what's really intriguing. You know, you might just be doing surgery in that moment, but you're also thinking about function and how is this person or patient going to function 5-10 years down the road. I know we're on the radio here, but let's set this up so our listeners can really appreciate what we're talking about here. So when you do a total hip replacement, you are basically taking off the ball portion of the hip, and you put a prosthesis in there with a stem, and the stem goes down essentially in the shaft of the femur, and you're either going to glue that shaft or you're going to do bony ingrowth. Tell us about those decisions to glue it or let the body ingrow bone into that prosthesis.
The total hips, when they were first developed, were always secured inside the bone with bone cement. Again, they have to be rock solid in the bone. And one way to do that is to use an acrylic cement, similar to what the dentist uses when he fixes a bridge or a crown in a tooth. Over the years, we began to note that a certain percentage of these implants would work themselves loose because the bone cement would lose its bond and would fail. And so the industry looked to solve that problem, and they went to a type of implant that's called a bony ingrowth implant. And that implant has a porous surface, and it's usually titanium, although it can be more like stainless steel. But that porous surface, if you could cut through it and look at it under a microscope, electron microscope, it has a porosity that's very similar to the porosity of bone. And when you machine the bone, you have to machine the bone very carefully, and then you really pound this implant in pretty forcefully. It has to be rigidly tight in the bone, and then the bone reacts as if there's a fracture, and it will actually heal to the porous surface of that implant, and that provides the long-term stability of that implant in the bone.
And as a surgeon, how do you determine who gets glued, essentially, or who gets bony ingrowth?
Our implants and our implant designs have improved so much over the years that now almost everybody gets a porous ingrowth implant. We still will use bone cement on occasion on the femoral side only, on the thigh bone side, in patients where the bone quality is quite poor. And that's usually people that are very elderly and have osteoporosis. And if the bone quality is poor, you worry about pounding an implant down in there that you might split the femur and cause a fracture, or the quality of the bone just may not be good enough to support that cementless implant. And so we'll use bone cement for them. And typically that's an older patient, and the bone cement doesn't usually fail early. It fails after many years. And so if you have a patient that's quite older, as they get older still, they start to slow down a little bit. And so it's less likely that they would loosen their implant due to bone cement failure.
I guess my question is, this is really interesting stuff. I mean, because as a surgeon, you need to estimate how big a shaft you put down in the inside of that femur. How do you know that? I mean, are you looking at an MRI? Are you doing it from an X-ray? And can you tell the quality of bone from any testing before you get in there? Because sometimes you actually get into the hip and you have to change course based on what you find in there.
Typically, it's almost always done just from regular plain X-rays. If there's any significant deformity, pre-existing deformity, maybe a prior fracture or some sort of congenital deformity, we may need to get a CAT scan. MRIs are not typically that helpful when you're looking at bone architecture. But most of the time we can do it just from X-rays, and then we have what we call templates. And it used to be in the old days that we'd pull out these plastic templates and line them up with the X-rays, and now it's all done digitally on the computer. But you basically plan out the positioning and the sizing of all the implants on the computer before you even go to the operating room. So it's pretty uncommon that you have to make any major changes when you get in there.
Kind of interesting stuff here. We're talking, obviously, medicine. We're talking physics, engineering, and we're talking a little bit of just hand-eye coordination and carpentry. I mean, that's, I hate to just kind of put it at that level, but that's really what it is. And I've seen you folks work and go in the OR, and really it's fascinating what you do and what is happening today with options for people. We've talked about John Kerry a little bit, and we know that he had a bike wreck, and it sounds like he fractured his shaft of his femur distal or below the implant. As a surgeon, what are the challenges when you see someone like that?
Well, again, you need to, number one, assess the fracture itself, where it is, what the pattern of the fracture is, whether it's particularly comminuted. In other words, sometimes there'll be several pieces as opposed to a nice clean break. And then also you need to try and assess the stability of the implant. If the implant is stable and the fracture occurs distal to the tip of that stem, then you simply have to concern yourself with fixation of the fracture. And that's typically done with a combination of plates and screws and wires and oftentimes bone graft that we get from the tissue bank. And I've always been a big believer in that you really can't make that femoral reconstruction too stable. In other words, overdo the plating and the bone grafting as opposed to underdoing it, because from the minute you have finished that operation, it's sort of a race between the bone healing and your fixation failing. And if that bone doesn't heal faster than the fixation breaks or comes loose, then your reconstruction will fail and you'll have to redo it again. So the more stable you make that fracture, the better your chances are that everything will turn out well for the patient.
And in that area of the fracture, we're talking about the shaft of the femur. Is that a pretty easy area for healing, or is there some challenges for bony growth there?
Femur fractures generally heal pretty well, but it's interesting that oftentimes the more straightforward appearing one, in other words, a nice transverse fracture right in the middle of the shaft, that can actually be the hardest one to get healed, because the fracture will heal more readily if there's more surface area of the fracture that you can reoppose, if you will. So if you have a long sort of spiral type fracture, there's lots of surface area of bony contact for healing to occur. If you have a nice short transverse fracture, there's a much less surface area of bone, and that's actually harder to get healed. It's a more unstable fracture, and you better make sure you've really got the fixation stable, or the fracture won't heal quick enough, and oftentimes the fixation can fail.
See, there's that physics component I talked about. Tell us, over the years in your experience, what is the most interesting thing and most exciting thing you've seen in total joint replacement? Because you mentioned a little while earlier, when you started out, you did a plastic template, put it in there. So what are some advancements that have been really good for the patient?
Well, golly, there's been so many in the 25 years that I've been here in Seattle that it's hard to really say. But I think probably one of the things that has contributed most to the longevity of these artificial hips has been the development of highly cross-linked polyethylene. The sockets that we put in for the hip replacements are a titanium socket and then an insert of some sort. And prior to 2000, we had just standard polyethylene, and the problem was that wore out pretty quickly, and sometimes in as early as 8 or 10 years, that polyethylene was worn out, and you had to go back in and take the polyethylene out and put a new one in. And oftentimes there may be quite a bit of bone loss around the socket as a result of a bony reaction to all of this plastic debris, all these billions of particles of microscopic polyethylene. The industry, not me, I didn't have anything to do with it, but the industry tried to solve this problem initially by going to maybe hard bearing surfaces like ceramic inserts, ceramic on ceramic.
I remember those.
Or metal inserts, metal on metal. For a variety of reasons, those haven't worked out as well. But also, a part of the industry worked towards trying to improve the quality of the polyethylene, not only in the durability of it, but also in the sterilization technique. And the highly cross-linked polyethylene that came on the market around about 2000, 2001 is proving to be vastly superior to the old polyethylene. And now we have hips that are in there for 14, 15 years, and you can barely measure any wear whatsoever. And so, whereas before I used to put a total hip in somebody and say, you're probably going to have this redone in the next 10 to 15 years. And now I look at anybody over 50 and say, this hip should last you the rest of your life. And that's a remarkable change.
And the reality is, probably when you got started, because I remember when I got started, I mean, they didn't do total hips on 50-year-olds. I mean, usually you tried to kind of buy some time and get to 55 or 60 just because the implant wore out.
Sure, it was going to fail, and you were going to have to do it over and over and over again. But now we really don't have nearly as much concern about that because of the success of this highly cross-linked polyethylene.
Well, once again, thank you for your time. Good stuff, great information. If our listeners wanted to ask you a question regarding their hip or bony problem or any orthopedic question, how would they get a hold of you?
The best way would just be to go to our website. It's OPA Ortho, and there's all sorts of contact information and general information on there, as well as some links to some procedures and whatnot. I think that would probably be of interest.
Thank you.
If you would like more information on this topic, as well as how to contact Dr. William Wilson, go to irgpt.com and click the Help tab.